So this place is killing me. My sort of thesis or main message is that population health as an objective for urbanism is really coming back onto the agenda very strongly. In Herbie's slide, there was a point in 2010 where you'll see that 50% of the world's population was urban, and the rural population was as well as 50%. So there's a sort of crossover point there. And at that point, the UN Habitat and WHO published this document called Hidden Cities, unmasking and overcoming health inequities in urban settings. And they said there's triple problem to health in cities. One is infectious diseases, and I'm not going to be covering that today. The second is injuries, including road traffic collisions and violence. We'll be dealing with road traffic collisions to some extent, but my talk is mainly about non-communicable diseases. And ironically, these are trivialized and sometimes called lifestyle diseases. Lifestyle diseases like heart disease, it's a lifestyle choice, cancers, diabetes, asthmas and strokes. These are the lifestyle diseases in the public health world. In Bristol, we've created a unique health partnership called SHINE, which actually bridges public health professionals and built environment professionals, embedded in Bristol. Wrong way. Ooh. I think I pressed the wrong button here. I think I pressed the bottom one. Oh, there. Oh, yeah. We're on again. It was just on and off. Thank you. I ran this past someone last night, the presentation. They said, you know, there should just be 3 points that the audience are left with. So I'm going to do those at the beginning and do them at the end, and then maybe find out at lunchtime whether you've got those messages. So one is the places we create determine our health. We can't afford the lifestyle disease epidemic, and our work here as urbanists profoundly influences people's health. The WHO centre that I'm involved with works across Europe on the Healthy Cities programme, which is now this autumn celebrating 25 years of work. And these are the sort of cities, you won't be able to read that, but you get that sort of larger WHO regional Europe, which actually covers Russia and Turkey as well. And we work with these cities in linking placemaking and health. And this is a sort of model that we use for this. It's called the determinants of health and well-being in our settlements, could be in our cities, could be in our neighbourhoods. There's a scale dimension to it. But we're looking at people at the centre here, and to what degree are they healthy or not? And that is not just because of their sex, hereditary factors, etc., age, but there's a lot of other determinants of health, and a lot of them are determined by the environments, the urban environments that people live in. And a lot of them, as urbanists, as architects, as built environment professionals, planners, developers, we influence, particularly in that blue sector. Our interventions are in that sector, and that can directly influence people's health, but it also influences it through a cascade of impacts through this system. So this is just a concept. It's a dynamic system. We use it for health impact tracking. It's not a statement of what is, it's a statement of a dynamic system. But we could say also, what's the problem? For us, this place is killing me, but it's not actually killing me or you, because there's a huge social gradient involved here. We're probably not the places not the people that places are killing. So there's a theme of equity that runs through public health work that I think used to be much more evident in urbanism and in built environment work. The other thing, you know, what's the problem? It's probably quite good for the economy, isn't it? Probably quite good for GDP. The more ill people, the more demand on the health sector. The health sector is strong, big pharma, high-tech clinical equipment, research, employment. There's a perversity of economics here. So the wider determinants of health. Now, I sort of have to move between two worlds, built environment and public health. And when you get into public health, there are some statistics involved. And so bear with me on this. But I'm going to test you on some of these statistics. And you can confer. So this is a participation bit. So, and it's getting a feel for some of the evidence, priorities, and causality as well in quite a quick way. There's just 3 bits to this. One, how many cyclists are killed or seriously injured every week in the UK? Okay, you can confer. Come on, I'm going to ask you in a minute. What do you reckon? It's killed and seriously injured together every week in the UK. What is that? Okay, what's the starter for 10? Starter for 10, anyone? Up, higher, 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 higher. 400. Well, all right, sold. 400 cyclists a week. Where's the headlines? Where? That's killed or seriously injured. Within that, 2 are killed. The seriously injured is the big. So public health, you know, we had, was it a year ago, we had this measles outbreak in South Wales. It was all over the BBC. It was all over everywhere. How many kids died from the measles? You know, but people are being slaughtered on the roads. Cyclists. I mean, it's weird, isn't it? Where are the priorities? Okay, we'll go for one more. What percentage, this is from a CABE study, a Commission of Architecture and Built Environment, what percentage of people in England in social housing use green space when it is on their doorstep? What are we getting there? 10, lower, lower. 5, lower, lower. It's 1% from the CABE study, 1%. But then what's it say about the green space? Have you seen some of that green space around social housing? You know, would you be using it? You know, so there's quality here, evidence. The final one, which I won't ask you about, but it's an interesting one. Heat-associated deaths. Remember the big heat wave 2003 across Europe? 25 degrees all night long for, I think, several nights running. France saw 15,000 deaths. UK saw 2,000 deaths, sort of excess deaths. Mainly elderly people here. So what was the major killer in those heat waves? And we've got sort of climate change overtones here, haven't we? Was it high temperatures? Or was it loneliness and isolation of elderly populations? And what does that tell us about how we should be preparing cities in an atmosphere or to accommodate the aging population? So public health causality and the way we've spun causality or used causality are totally different. And I sometimes get caught up with public health like this sort of medical causal chain, but I think we're working much more in this complex causal web. So the focus is non-communicable diseases associated with built environment, and we've rid cities more or less in developing countries of rife communicable disease attributable to poor design through the 19th century. But we now see the rise, again, we could say attributable to poor urban design, of these sort of lifestyle trivial diseases, And urban planning has a huge role to play with these non-communicable diseases. The economic dimension, and this comes from some work that Wanless did for the Treasury, the Wanless report, where Sir Derek Wanless projected the total proportion, percent of GDP that we would have to spend on the NHS going forward. He did the report. It was based on data 2003, and it's projecting up to almost 2025. And it comes out with different scenarios. And you can see this massive spend. And this is what we're hearing, all these hospitals and health trusts going into deficit. It's trying to cope with this. And he has 3 scenarios here. The top line is this sort of unaffordable one. And the black one at the bottom is called fully engaged. And what he's saying there is that it's not up to the hospitals to mop up the disease. It's up to us all to feel the responsibility in our professional lives about what we're doing, the actions that could be causing disease or not, because we can't afford to mop up the illnesses. So that's the preventable track. He's called it fully engaged. I don't really think he really factored in urbanism, town planning, built environments, landscape architects, planners, what we can all do, transport engineers, transport planners. I think that bottom line could be lower. So that introduces you also to that wider workforce concept, which the public health actually funded us to look at for a while, and that's partly funded the work we've done with Bristol. It's planners and transport engineers, etc., and the whole gamut as part of the wider public health workforce. But we've got an NHS, and we're spending all this money. So in a way, ill health is good for the economy. So let's bring it on then. So noise, and Herbert already mentioned air quality. I'll come on to air quality, but noise. So a study across Europe, excessive or persistent noise exposure from urban sources can have a detrimental effect on health, obviously, impacts on cardiovascular disease, sleep disturbances, annoyance, mental health, hearing impairment, cognitive impairment. The grand total is 26 million disability-adjusted life years for Europe. So that is 26 million people having 1 year of their life spent in a disability they wouldn't otherwise have with the noise, or one person spending 26 million years with a disability. Massive. And it's not, the most of the noise is from internal combustion engines in urban areas, and it's low-level persistent noise that we're talking about, not the sudden pneumatic drill, that sort of thing. It's low-level persistent noise, meaning stress, higher and elevated levels of stress over a long time, over maybe 10, 20 years, just that constant stress. Physical inactivity, here's a good one, and this comes from the Director of Public Health report for Bristol. 15,000 deaths a year in Bristol due to physical inactivity in adults. Sorry, 1,500 deaths a year, physical inactivity. Road traffic collisions only account for 9 to 10 deaths in Bristol. Again, where's the priority? That's what we've got. Air quality. Most of exposure is associated with the urban environment, and in particular the emissions from internal combustion engines. In Europe, it's about 400,000 early deaths. In the UK, we're talking about 29,000 early deaths. Drilling down to Bristol, per year, 188 deaths of Bristol residents over the age of 30 attributed to air pollution in 2010. Within these, 24 deaths attributed to the pollution from local road transport emissions. So 24 deaths a year from road transport emissions, 9 or 10 from road transport collisions. But of course, the causality, someone bumps into someone and they die, you've got the causal link there. And that's the headlines want the causal link. Moreover, many of these things, the noise, the physical inactivity, the air quality, they don't fall evenly across the population. Children, old people, those with heart and respiratory diseases, and those that are most at risk are those living in deprived areas. So it's not an even curve. That's why the place isn't killing us. It's killing some people. And there's been a sort of, I often come back to this, The Lancet actually published 2007, a great list of all the diseases associated, linked to the built environment. This is also not just urban design, this is also building design and emissions and toxicity from buildings. And we'll just run through this roll call. So it goes beyond cardiovascular disease, type 2 diabetes, cancer, and mental health. And this is the sort of thing in The Lancet, health problems with potential links to the built environment. So potentially some of the solutions are in our hands, maybe. There's 3 pages of this stuff, and some of the stuff I've never heard of. So public health policy comes into focus here, actually stopping it at source, not curing illness. So public health divides into, or health divides into the illness services and public health. I used to think, before I did all this public health stuff, that public health was just those posters in the doctor's surgery, like teenage cancers and smoking cessation and sexually transmitted diseases. Public health is much bigger. In the UK now, there's a director of public health in every local authority who seeks to secure the health of the population, enable them to have healthy lifestyles, to have access to good food, to green space, to cycling, to physical activity. So public health policy, choosing health, there was a big campaign, choosing health. For political reasons, the funding of public health policy focuses on individuals, personal lifestyles, personal choice. NHS even funds personal health trainers, tell you how to eat, where to walk, how to relax, and how to think, CBT. So here's a member of our ageing population. She's quit smoking years ago. She knows nature's good for her health, so she's grown some plants. Maybe she can even eat those plants. She's eating her 5 a day. She's doing a 5 by 20 minutes exercise. Alcohol units are under control. All this stuff, this guidance, but something in the picture is still wrong. And that's not the satanic mills of the 17th century, of course. It's that urban environment, and it might even be the local hospital, which turn their back often on eking out health into the local population. They're surrounded by car parking. It's not an agenda of physical determinism. We can't just build fit cities. It's not about that. So we failed that way. It's not about one pattern. However, a significant number of lifestyle diseases are preventable. It trivialises individual choice, but we build the risk factors into towns and cities. And again, the public health press are labelling places as obesogenic, as depressogenic, even pathogenic. Here we are at the sort of bottom of the league of obesity across a clutch of European countries. And at the beginning of the life stage, we have the husky, the special husky, Britax husky child seat for the obese 3-year-old. It goes right through the life stage, and at the end of the life stage, there's the supersized coffin for the large, obese American. So we build attractive homes behind walls in unattractive neighbourhoods, and there's no concern for population health in this. We do strung-out facilities, relatively inaccessible by foot. No concern for population health in the design of this. Lavish office and retail parks, 90% car dependent. No concern for population health. The market's not going to live in places that support healthy lifestyles. Do we leave it to the market to deliver and build social capital and to create inclusive communities? We're now even sort of building toxicity into our Portas branded high streets, if you like. Addiction, betting shops, money lenders, fast food takeaways, cheap alcohol, tanning shops, the new sort of vaping. What's vaping? It's those electric cigarettes. And the jury's out on public health, whether they're increasing smoking or decreasing it. But the jury's out. Then they could be very risky. But look, rolling back a bit, this is the definition of health in the WHO Constitution 1946. Health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. I think we've lost that definition. Interestingly, you've picked up on the definition, the Academy of Urbanism. If we look at your principles, and I've just tried to pick out in green where the health is, it's written all over it. So you're there. You are the wider public health workforce. So just go back to the health map. The population health is not determined by the hospital, the doctor. They're part of the illness service. Population health is determined by easy access to work, strong communities, local parks and environments that support walking and cycling, and feeling we have control and buy-in to the change that's happening in our neighbourhoods. This is the territory of urbanists. Your actions influence health for good or for ill. You're an important part of the wider health workforce in an era of increasing obesity, ageing populations, widening inequalities in disability-free lifespan. So we use this tool with communities to make sure that health enters into the process of planning and design at neighbourhood planning level. We use it with professionals. We've taken 2 trips of directors of public health and chief planners out to Freiburg to see Wolf, and more recently taken them to regeneration schemes in the Netherlands. This is on our trip to Freiburg. But isn't it all just good design anyway? So, what's public health bringing to the party? And I often think about that. But good design isn't the norm. And the offer, I think there's an offer of support from public health. And it's a two-way thing. We're all public health, but public health has something to offer. Advocacy. They are brilliant at supporting population health. They advocate for it very strongly. Evidence. They provide good quality data. Equity. This is something they specialise at. Ensuring inclusion is a priority in all those marginalised and vulnerable groups, whether they're subpopulations in the centre of the city or neighbourhoods on the periphery. And economics, reducing the burden of disease. And I'll say something about that in a minute. So the places we create determine our health. And we've got to build alliances with public health practitioners for healthier placemaking. In Bristol, we've actually had something called a Healthy Urban Team embedded in the City Council. I work in that over here. I'm half a day a week, usually every Wednesday. I'm in the City Council, interacting with a consultant in public health who looks at climate change and food. We've got planning and health specialists, Active Bristol, transport planning and health policy. And we have helped the rollout of the 20-mile-an-hour zones in Bristol, around the advocacy, around the evidence base. We'd helped with the Playing Out initiative in streets. We have a protocol in place for doing health impact assessments of planning applications now. We've done community walking health audits out in neighbouring communities, dealing with the food system across Bristol, development management policies. We've done a lot of things. All this will be explored more, if you're interested in this, in a Healthy Cities Conference, Cities of Health, part of the European Green Capital, October 2015, examining this in all its dimensions. And this team also, just the final point on the economics, and this is sort of quite pertinent to the Garden City workshop, we were posed a challenge by the Town and Country Planning Association. If you build out in a sort of, let's take Freiburg as a model, that style, or if you build out business as usual, which in Bristol sometimes we call Bradley Stoke, that's a lot of cul-de-sacs, that's not a lot of facilities at the beginning. You could build out in these two styles. What's the difference to the public purse over the next 30 years in picking up the ill health associated with one of these styles? And we've made a very conservative estimate, and for every 1,000 homes, and we've done modest guesses on reductions in mental health, circulatory disease, respiratory illness, musculoskeletal disease, type 2 diabetes and injuries, and we think that over 30 years you've got a £2.4 million saving to the NHS per 1,000 homes. But of course the economics trick is we let the NHS pick up that cost because we can't capture that 2.4 million and put it in at the beginning. And it's not going to cost an extra 2.4 million per 1,000 homes anyway. As we've heard earlier, some of this can be done virtually at the same cost as houses now. So the 3 points that I began with, that I'm going to end with, the places we create determine our health. We can't afford the lifestyle disease epidemic, and our work influences people's health. Thank you.